Hello, my name is Kahtan Fadah. I'm a third year internal medicine resident at Texas Tech University of Health Center El Paso, and also a CardioNerd Academy Fellow and a Academy Journal correspondent. Today, as part of the CardioNerd coverage for American Heart Association 2022 conference, I have the distinct honor and privilege of inviting Dr. Gregory Piazza to speak to us about Prevent HD late-breaking trial. Among his many titles, Dr. Piazza is the director of the Vascular Medicine Section, Cardiovascular Medicine Division at Brigham and Women's Hospital. He's also an associate professor of medicine at Harvard Medical School. Dr. Piazza practice focuses on evaluation and management of prevention of venous thromboembolism and so many more. Dr. Piazza, we are very thrilled and excited to discuss with you the Prevent HD trial, which will be presented this year at HA 22.
Thank you so much for welcoming me and for inviting me to tell you a little bit about our trial.
Okay, let's begin with the first question. COVID-19 has been associated with both venous and arterial thromboembolic event. Can you please share with us the motivation and the rationale behind the trial?
Absolutely. So as you very nicely mentioned, early in the pandemic, we became aware of what seemed to be a very high rate of arterial and venous thrombosis. Around that same time, there were some histopathology studies that started to identify both macrovascular and microvascular thrombosis as an important part of the pathophysiology of COVID-19, and perhaps with microvascular thrombosis being one of the key components of the clinical deterioration that we saw with COVID-19. Now, even early in the pandemic, while we were dealing with hospitalized patients, the vast majority of those patients who were infected with SARS-CoV-2 were actually treated as outpatients. And that left a very large population potentially vulnerable to these macrovascular and microvascular events and potentially deterioration leading to hospitalization. So that was our primary focus.
Yeah, that's phenomenal. And speaking from experience, we've seen those cases happening in the hospital, yet we didn't have an answer. And this this is a great way to answer the question that we all had. So I know there was extensive eligibility criteria specifically to fit this trial. Can you tell us a little bit more about that?
Yes, absolutely. So again, we were focused on outpatients, people who had never been admitted to the hospital. They had to have clearly proven COVID-19. It had to be symptomatic. And then what we were looking for was at least one additional risk factor for adverse outcomes like thrombosis, either age greater than 60 or prior history of thrombosis, underlying thrombophilia, vascular disease, including CAD or PAD, cancer, diabetes, heart failure. It could have been also body mass index greater than or equal to 35. That had emerged as an important risk factor. And then some patients who had D-dimer testing, if that was increased, that would satisfy our eligibility criteria.
Thank you for sharing that with us. So as you know, the COVID-19, in a pandemic, required an innovative design. How did you come up with this unique aspect of your an innovative approach to meet that need?
Absolutely. Well, I think a lot of it had to do with the restrictions that were placed upon us by the pandemic. We had to create a completely touchless clinical trial, one that was conducted virtually, but still maintained the rigorous monitoring of our patients for safety reasons, but also to assess for outcomes. And so what we did is we created a trial that used a computerized decision support tool to identify patients who had COVID-19. We reached out to them via telephone or virtual visit to gauge interest and to talk a bit more about the study. And then if they were interested, they did a virtual consent, and then they received their medication, either the study drug, which was rivaroxaban 10 milligrams once daily, or a placebo via a centralized pharmacy. And then we were off to the races, monitoring them with phone visits and making sure they were doing well and tracking their events.
Wow, this is phenomenal. This is the first time that I hear about such trials done this way, and I think it's a unique aspect that could be carried over even after the pandemic. So can you tell us about the demographic of your patients in this trial?
Yes, absolutely. So first of all, both populations, the rivaroxaban group and the placebo group, were very well matched. As you can imagine, because of the entry criteria that we had, our population tended to have a higher body mass index. We were very fortunate to be able to enroll a very diverse population. Almost 30% of the patients were non-white. We had very good balance in sex, with actually closer to 60% being female. And the median age was around 55, 56 years. So a very nice representative population of what we saw throughout the pandemic in patients exposed and then being diagnosed with COVID-19.
Yeah, that's definitely a well-diverse group. It's really important to have that, especially when it's with the COVID-19, and we know some diverse population were including Black and Hispanic community were hit harder than other population.
Absolutely. I think we felt that if we didn't enroll a diverse population, then we really weren't representing the communities at risk.
Correct. Thank you so much. What were the key findings of the study? I mean, did rivaroxaban reduce the outpatient major venous and arterial thrombotic events, hospitalizations, any of the primary endpoint?
Sure. So our primary endpoint was a composite of thrombotic events, including venous thromboembolism, but also arterial events, all-cause hospitalization, and death. And we did not observe a difference in our primary efficacy outcome between patients who received the rivaroxaban versus patients who received placebo. And that was in line with a number of smaller trials. We were able to enroll 1,284 patients, and that's what comprised our intention to treat analysis. And that really is the largest collection of outpatients studied in a trial like this focused on thromboprophylaxis.
Okay, and no, thank you for elaborating. Can you tell me why when I was reading about the trial, I wanted to understand, or the design, why was rivaroxaban chose among all the oral anticoagulation therapy?
Absolutely, great question. So rivaroxaban was selected because rivaroxaban already had an indication, an approved indication for thromboprophylaxis in the medically ill. So it seemed like a natural option for a study like this. It's once daily, and so convenient for our patients to take. And it had a track record for safety that was really demonstrated in a number of trials, including post-discharge studies, showing that the bleeding rate was consistent with what we see in prophylactic trials. We also expected it to have efficacy at the very least for preventing thrombotic events. And in one of our additional analyses, it was a post hoc exploratory analysis. We actually did show a significant reduction in thrombotic events with rivaroxaban, sort of in keeping with what you would expect from a direct 10A inhibitor used in a prophylactic manner.
And how did you reach to use the lower dose of rivaroxaban, like the 10 milligram dose, um, for, especially for in a prophylactic aspect?
Well, it's a good question because many other realms of thromboprophylaxis in COVID-19 were focused on higher doses, greater intensity of prophylactic anticoagulation, especially on the inpatient side and in the critical care setting. But we felt that for an outpatient population, the risk of venous thromboembolism, arterial thrombosis, and possibly this microvascular thrombosis would be there, but it wouldn't be there to the level that you might see in a hospitalized patient. So the already approved dose of rivaroxaban 10 milligrams once daily for thromboprophylaxis seemed like a good fit. These are otherwise patients who wouldn't be hospitalized, so we wanted to make sure we were mindful of bleeding risk as well. And so this seemed like the right drug for the right patient population.
No, I like it's really obvious how much thought was put into minimize the bleeding risk, as well as the efficacy and the safety. And this is bringing me to the question is, did you face any difficulties with patients who are taking dual antiplatelet therapy, or or maybe in a higher dose aspirin, and so on and so forth?
No, it's a terrific question. And those were patients that wouldn't have been eligible for the study, patients on dual antiplatelet therapy. If the patients were on low dose aspirin, they were allowed to continue that. And the emphasis there was really to protect the safety of the patient population. And we were very pleased to see in our study there were no fatal or critical site bleeds, which was our principal safety outcome, and no difference in ISTH major bleeding. So I think the patient selection was key there in making sure that we could explore this in a safe way with our patients in PREVENT-HD.
Thank you. So when it comes to we've noticed over likely over the past few months and so on and so forth, the trend of mortality with COVID patients have decreased. However, how do you see this clinical trial change our clinical daily practices?
Yeah, I think that's the big question for all of us. I think that when you look at PREVENT-HD in the context of other trials that have also focused on the outpatient setting, I think the data all particularly are consistent in that for routine management of outpatients, patients who are not being hospitalized for COVID-19, all of these studies sort of demonstrate that there isn't a role for thromboprophylaxis in a broad sense for these patients. Now, there may be very high-risk patients that have enough of a thrombotic risk where this might make sense, but at this point, based on the trials we have, we would not, I don't think anyone could recommend blanket prescriptions of thromboprophylaxis for non-hospitalized patients with COVID-19. And so I think that our study adds, and being the largest study, gives more confidence to clinicians out there that they don't need to necessarily prescribe thromboprophylaxis in addition to all of the other things that provide challenges for taking care of COVID-19 patients.
Definitely, I used to think about that, when it comes to my patients when they call from to the clinic and they're asking, what should I be doing? I've tested positive for COVID and I have these symptoms and they're higher risk. And that question always came to my mind, and we had to discuss it earlier, but I think with this trial we could go with no doubt that we've had our question answered in the most appropriate and safe way. Thank you so much for elaborating in this. Dr. Piazza, let me congratulate you on this remarkable and influential results that will change our practices, or keep us informed of what we going to do forward. We are beyond excited to have you present these results in person at American Heart Association conference and meet you in person. Thank you for joining us this morning. It's been an absolute an honor and privilege to be here with you today.
Oh, well, the privilege has been mine to be able to share the results with you, and it is our sincerest hope that Prevent HD will help to provide clinicians and patients with a little bit more confidence in what seems to be this never-ending pandemic.